My name is Alyssa Margolis, for anyone who doesn't know me, and this is an addiction-centered talk today for the Pain and Addiction Research Center. We are a transdisciplinary center spanning UCSF clinical and research communities to advance pain and addiction science and care. Please follow the little QR code for more information. If you don't have these events on your calendar yet, please note that we have a series of pain talks coming up this spring, including in April from Judy Pace on cancer pain policy, as well as from Jessica Merlin on May 22nd on cancer pain translation. PARC also has a call for applications right now for the 2024 fellowship. There's information again at this QR code. You have a few weeks before the deadline. This opportunity is open to UCSF faculty members in all series, including adjunct, and at all levels. So please go ahead and take a look. We also have a neuromodulation symposium coming up on April 20th that there's more information at this website, a day-long event on neuromodulation for a variety of different indications. So I'm very excited to introduce today's seminar speaker, Dr. JHom. Jeff is an MD, MPH. He is board certified internist in the San Francisco Department of Public Health, where he helps lead the department's overdose response and efforts to reduce the individual and collective harms associated with risky substance use. Jeff received his MD from Harvard and his Master's of Public Health from the Harvard School of Public Health. And he completed his residency in internal medicine in primary care here at UCSF. Jeff was then a fellow at the Robert Wood Johnson Foundation Clinical Scholars Program at the University of Pennsylvania, where he obtained his Master's of Science in Health Policy Research. In the Philadelphia Department of Public Health, he established and directed the Division of Substance Use Prevention and Harm Reduction, helping to lead the city's response to addiction and overdose. He is currently pursuing a Doctor of Public Health as a Bloomberg Fellow at the Johns Hopkins Bloomberg School of Public Health. And today, Jeff is going to discuss with us policy challenges and opportunities in today's overdose crisis. So Jeff, thank you so much for joining us today, and please go ahead and take over.
Great. Well, thank you, Melissa, and everyone for the opportunity to be here today. I really appreciate the chance to present, but really more importantly, to have time to engage with you all at the end of my slides here, because I really sort of look forward to hearing your thoughts and expertise, on this area and in this field as well. So with that, I'll just sort of jump right into my agenda here. Over the next, I'm aiming for about 35 minutes or so to allow for, really what I hope will be a robust discussion. I'm going to start with some national and local data, much of which will be familiar to you, talk about some of our overdose prevention initiatives in San Francisco, and then really spend the bulk of my time talking about policy. And I'm hoping that that policy side of this discussion will sort of complement other seminars, other speakers that you've had talking about addiction and today's overdose crisis. And then I'll end with just some final thoughts and then really open it up for questions. But then again, I think I have my own sort of questions for all of you as well. So with that, just sort of diving into some of the data, certainly, overdoses remain a profound national public health crisis. The graph on the left there are national data from the CDC, showing that in 2021, we ended that year with over 106,000 individuals dying from unintentional drug overdoses across the country. That is staggering, certainly in its own right. And then this article came out sometime last year, pointing out that Dr. Rahul Gupta, who is the director of ONDCP, our country's drug czar, as it were, projected that up to 165,000 lives might be lost annually by 2025. So in just another year's time, our deaths may increase by another 50%, which is just also, sort of heartbreaking. Not that earlier on in this crisis it was less heartbreaking, but just sort of seeing the magnitude of the number of people who are dying really sort of continues to remind me of the importance of the work that we are all doing to try to change the trajectory of this public health crisis. We are indeed an epicenter of this crisis, I would say, sort of nationally and certainly in the state. Our overdose deaths increased in San Francisco in 2023 compared to 2022. The graph on the left here are data from our Office of the Chief Medical Examiner, so part of the city administration here. And what it's showing is preliminary unintentional overdose deaths by month. And as you can see, we've had sort of a steady rise through 2022, through 2023. And we ended 2023, as of right now, with 813 preliminary overdose deaths for the last calendar year. Some of the cases are still outstanding, so that number will only go up as the final cases are closed for 2023. But as it sits right now, we are 166 deaths above where we were in 2022, or 26%. And that sort of increase, just, we don't see that in public health. Such a year-over-year increase, really suggesting that this is really, as the previous graph showed of national data, really affecting so many people, every corner of the city, every community, I would certainly argue, is being affected by this crisis locally. And that's sort of what we also see on this map here. So the heat map on the right is the location of our 2022 decedents, a year that we had 647 people dying from unintentional overdoses. We obviously have that very dense hotspot, that cluster in the northeast part of the city that we all recognize as the Tenderloin and South of Market neighborhood. But the map also sort of shows that deaths are occurring citywide. Every sort of corner of the city has some of those dots. You can sort of look at the northwest, the southwest, down to Bayview, over on Treasure Island. Deaths are indeed occurring across the city. The majority of our deaths do occur inside a residence, which is something that I bring up because I think it also is always an opportunity for me to ask this question. That group, people who are dying in their homes or in the homes of someone they know, are oftentimes hard to learn much about, hard to reach, offer services to. And so I sort of pose this question for people to think about. Are there ways that we can sort of reach a population that may have more resources, may be using drugs in their homes or in sort of more private spaces, and how might we think about engaging those people? So again, our deaths are occurring citywide, but they also do disproportionately impact people who are experiencing homelessness. And so according to the Office of the Chief Medical Examiner, between 25 and 35% of our overdose deaths in any given month occur among people without a fixed address, meaning that they are presumed to be experiencing homelessness at the time of their fatal overdose. This is the other slide that we put up in every single one of our presentations, because this is the other population that is disproportionately affected by our overdoses locally and also nationally, is that we do have these profound racial disparities. Black African Americans represent just 6% of our population in San Francisco. That number alone has been declining, yet they represent 31% of our preliminary overdose deaths in 2023. So another way of sort of just putting this is that the overdose death rate among our Black African Americans in the city is 5 times higher than the citywide rate, which is what is depicted on the graph on the left. This is my last sort of slide where I'm sort of showing just sort of a lot of sort of local numbers here, but just to sort of make the point that, again, this is something that you all know well, is that fentanyl is really what is driving our overdose deaths locally and again nationally, followed by methamphetamine and cocaine. So this graph on the left here are from our monthly reports from the medical examiner's office showing the cumulative accidental overdoses by day of death for 2023. So this is where we end the 2023 with that preliminary 813 people dying. This is the total number of unintentional overdose deaths, and then it's broken down by substance below it. So 657 decedents had fentanyl present in their toxicology, 412 individuals had methamphetamine, 373 had cocaine, and then the very, very bottom here, very relatively speaking, small numbers, 52 people dying with prescription opioids or medicinal opioids, and then 39 with heroin. Simply making the point that, heroin is very difficult to find in San Francisco, for one, and prescription opioids, which were once, much more common among our decedents, has really, given way to obviously fentanyl, which is driving our deaths here. Over 80% of our deaths in 2023 involve fentanyl, up from just 12% in 2016, showing how quickly the supply can change. And then in 2023, more than 80% of our overdose deaths involving fentanyl also had at least one other drug present. Maybe it was fentanyl plus heroin, fentanyl plus cocaine, or fentanyl plus methamphetamine. And that's sort of why these numbers here on the right-hand side of this graph, do not add up to 813. These are not mutually exclusive categories. Indeed, polysubstance use is certainly much more the norm than the exception these days, in San Francisco, across California, and across the country. With all of this sort of before us, we look at these data regularly within the health department and with our many partners across the city, and it's sort of informed how it is that we are thinking about approaching this crisis. What are some of the initiatives that we have undertaken both in the past year and really even before it? I would say that the picture on the right here is a screenshot of our overdose prevention plan that was released in late 2022, articulating what we thought was a comprehensive way of saving lives here.
So I have a quick question. Can I ask a question?
Sure, go ahead.
Yeah. So do you have any idea about the people that are sort of taking a certain drug like methamphetamine or heroin or whatever, and the ratio of the people taking the drug to the overdoses? In other words, are we seeing more overdoses because of the growth of the fentanyl in there, or are we seeing the growth of the overdoses because more people are taking opioids?
That's a really great question and a really important one to be thinking about. I would say probably sort of two different things about this. The first of which is that I think some of the rise that we have certainly seen in our decedents in San Francisco is due to the prevalence of fentanyl in our drug supply now. We certainly recognize how much more potent it is than heroin, and how even individuals who may have fairly high tolerances to opioids due to prolonged exposure to heroin or to other opioids may still certainly be at risk for a fentanyl overdose, especially when they're not sure how, in what quantity fentanyl may be in their in what they purchase. Nowadays, many people are actually seeking out fentanyl. They have such a high tolerance. That is what's going to address their withdrawal and their cravings. But knowing, when they make that purchase, not knowing the quantity and the purity are things that can certainly put people at a higher risk, even if they have some tolerance. At the same time, you're right that what is the larger population? It's very easy for me to count how many people are dying, how many people are receiving services, but understanding this larger population, this denominator, is something that we have struggled with. And that is not something that is, I would say that many cities are really struggling with understanding that denominator, because our data sources up until sort of more recently, perhaps, have not been able to estimate that for us. Surveys have their own limitations. There's a lot of stigma around this. That's going to underrepresent the population. We know certain populations themselves are not easily able to participate in surveys to begin with. Individuals who are in the carceral system, individuals who are experiencing homelessness may not have the same opportunity to participate in surveys. And so these are all problems that we are facing. I would say that it is something that we are working on with Dr. Paul Weston, who I believe is part of this, part of PARC, and has been really thoughtful about using more sophisticated ways of looking at data to help us estimate the size of this population. Because I think that's also important for us to know how much has the population, what is the population, and how do we think about scaling our interventions then, depending on what we learn. So I don't have certainly a perfect answer for you. I think it's a really important point, but I appreciate you bringing it up.
Thank you.
So with all of these things that we've been thinking about, and some of the points that you just raised there, Howard, around understanding the population better, what is it that we're able to do, at least with the knowledge that we do have? And so one of the ways that we've certainly been trying to think about our response is increasing access to this continuum of services in San Francisco. Everything on one end from more traditional harm reduction and overdose prevention services, all the way through residential treatment and sober living opportunities, medications for addiction treatment, and then specifically medications for opioid use disorder, are things that we have been investing in as a city, but not just the city. We certainly recognize we have so many partners who are in the community, social service organizations, healthcare systems, many folks at UCSF and ZSFG who have been really leading this work on the clinical side, have really participated in what we have seen as a growth of our response. And so roughly 5,000 people are being treated for substance use disorders in specific DPH programs. So this does not include individuals who are seeking care in some of our other healthcare systems in the city. Our ability our visibility into those numbers and those data are very limited. And so unfortunately, this is an area where, from a research perspective, I would say we are really limited, not only from a research, but also from a planning perspective of understanding, again, the breadth of people who are in need of services and receiving services. Nonetheless, this is what we do have at our disposal within the health department. Roughly 2,500 people in SF receive buprenorphine for OUD annually. That is more of a citywide number because that comes from the state's PDMP or cures. Roughly 2,300 people are receiving methadone for OUD annually. We have about 575 residential treatment admissions every year, and about 1,100 people are receiving withdrawal management services every year. On the other end of our work has largely focused on doing a lot of education to reduce stigma in the community, training individuals to recognize an overdose and to respond with naloxone if they do see someone who they are concerned may be having a fentanyl or an opioid overdose. And these are some of the numbers that reflect our work over the past year. In 2023, DPH and our partners in the DOPE project distributed about 120,000 doses of naloxone. That is about almost a doubling of what we distributed the previous calendar year. We had about 5,000 completions of our online overdose recognition and response training. And we're now really trying to do much more trainings in person. And so last year, we trained a little over 1,000 people in person on overdose recognition and response. Our other activities sort of in this regard are those on the right. We've been really working to develop new relationships with Black-led and predominantly Black-serving organizations. We have a collaboration with the Entertainment Commission. We have a request by mail naloxone program. And then really trying to just think through how can we make sure that naloxone is available at as many points ultimately as we can across the city. And I would say that we've done a lot. A lot has happened with our partners, again, across the city, in the community, thinking about the San Francisco AIDS Foundation, GLIDE, Homeless Youth Alliance. So many organizations are really been amazing partners and leaders, really whose work we are building upon. That was one thing I was going to say about our plan, was that this is the first time we've had a plan, but it's really been built on the successes of our partners in the community, advocates, people who use drugs, who have paved a way for us to think through what does a comprehensive response look like. In that regard, we've certainly also partnered with colleagues in the healthcare systems, ACT over at CSFG, the Bridge Clinic, have really been leaders in this space as well about really revolutionizing how we think about incorporating compassionate, harm reduction-centered, person-centered care into some of our healthcare institutions. Despite a lot of that, and I want to say that it's not for lack of a ton of effort on behalf of many people across the entire city, but that nonetheless, despite a lot of what has gone on, we still, again, had those record overdose deaths in 2023. And the picture on the left is just a screenshot describing, this was 2023 was our deadliest year, as it were, for drug overdoses. And I think the point that I'll make as I'm transitioning to talk about policy here is that we cannot arrest our way out of this crisis. But I would also say that I think with the complexity and the potency of today's drugs, we're also unlikely to solely treat our way out of this crisis and naloxone our way out of this crisis. That ultimately it's going to involve some balance, some combination of many different approaches, recognizing that people have different needs, People have different goals with respect to their substance use, and how are we meeting people where they are at, when they are at in that moment that they are seeking services? It may not always be treatment, it may be other sorts of services. How are we still engaging individuals who are using drugs and at risk of an overdose? And so much has sort of been made around, as we sort of think about this, is what's sort of been called the 4 pillars approach. This is not something that is new to us, but it's something that was sort of really brought to the fore by colleagues out in Zurich, who wrote a lot about this, described these 4 pillars approach to drug use, which is thinking about prevention activities, treatment activities, harm reduction programs and services, and then sort of law enforcement and thinking about the interdiction side of things. And I won't go into every single one of these bullet points. They'll all probably look familiar to you in different capacities. But in looking at these 4 columns and the bullet points below them, it's evident that we need to focus, that we tend to focus on programs and services, which are absolutely important, absolutely critical. But I would also make the point that it's policy that often shapes them and contributes to their successes. So although not always visible or explicit, policies really influence the drug supply itself. What programs are implemented and under what conditions are they implemented and can be implemented, how services are funded, and ultimately the conditions in which people live. And so I'm going to go into more of these, into some of these in greater detail in the coming slides, but I just want to make this point because I think it's important to note that policy underlies all 4 of these pillars. And ostensibly, really public health more broadly. A lot of what we sort of think about is, health in all policies. It's how are we also shaping the social determinants of health? Those are a lot of policy decisions. They're funding decisions. They're prioritization decisions, a lot of which really come back to policy. And so that is sort of what I'll spend the rest of my time here sort of sharing with you is my perspective on how our policy decisions have profound consequences for people who use drugs, and that we really must be attentive and critical, because just as policy can be used to advance the common good, it can equally impede individual and public health. And so to illustrate that point, I'm going to go through a couple of examples of good and bad policy, starting with some of the challenges, and then going to what I see as some of the opportunities that we have as a field, as a profession, to help individuals who have a substance use disorder, who are using drugs, and at risk of an overdose. And so with that, I'll just start with some of the challenges. And the first one here is I'll just sort of start with how our policy decisions, particularly at the federal level, influence the drug supply itself. And so this is an infographic from Filter Mag, from Filter, that describes sort of what's sort of known as sort of this iron law of prohibition, namely that the harder the enforcement, the harder the drugs. This is an important thing to think about given our country's history of how have we approached substance use. And we've taken from a very punitive war on drugs approach historically. And this is sort of the consequence. You can sort of see that this pathway is increasing law enforcement, results in increasing cost of illegality, the greater need to avoid detection, which results in more potent drugs because people are aiming to have less weight and volume, easier to hide substances, easier to store and transport. And that results in increasingly potent substances themselves. And so we sort of see, that the top row here is about alcohol, beer and wine, going to spirits, going to moonshine, cannabis, then high THC cannabis, and then ultimately to synthetic cannabinoids. And then the fourth one here is sort of, obviously what we're thinking a lot in terms of our overdose deaths, but opium, going to heroin, ultimately creating a market and a demand for fentanyl and carfentanil, which we are fortunately not seeing currently, but it's something that has come up in the past. And it's something that we need to be really aware of because we are sort of in this era with our drug supply being unregulated and increasingly toxic. And so this is a timeline of just the past decade or so, putting just a couple of pinpoints, a couple of milestones on this timeline, not comprehensive, not exhaustive, but back in 2016, the DEA issued this warning about carfentanil, which is sort of known as an elephant tranquilizer. It is up to 10,000 times more potent than morphine and 100 times more potent than fentanyl. So something that came up, more cases were sort of found in Ohio and parts of Pennsylvania. But subsequently, that has sort of gone, subsequently, we've not seen as much or heard as much about carfentanil in our drug supply. In 2018, we had an outbreak of synthetic cannabinoid-associated coagulopathy in Illinois. This was a case series published in the New England Journal. In 2021, there was published an article about an outbreak of novel psychoactive substance, sort of novel designer benzodiazepines. And then in 2023, certainly what was around before 2023, but made sort of waves in California about finally xylazine, or as it's known as tranq, as making its way into the drug supply and complicating our response. So this is just one example of how policy has influenced our drug supply, but policies have obviously, affected the environment in which we work. And now I'm going to come back to some of these other points that I made on this slide around how programs are, how policies are shaping our programs and our responses, and what some of the consequences of these policies have been. Because the pendulum, I'll just sort of say, is really swinging away from harm reduction measures right now. I'll say locally in San Francisco and in California. This is obviously an old screenshot, the one on the left there, from when Governor Newsom vetoed the bill for safe consumption sites or safe injection sites in the state. And then this one on the right is actually more from Philadelphia, but it's just published, I think it was like a week or two ago, that one of our harm reduction organizations in Kensington, which is sort of the epicenter of Philadelphia's overdose crisis, is being forced out of the neighborhood. Some of my examples on the forthcoming slides are sort of about my time in Philadelphia, which I think a lot about in the context of all of this work. And as I transition to the next couple of slides here, I just want to make the point that several commentaries have been written about how historical sort of law enforcement interventions, these more punitive approaches, never seem to need to justify their existence. They don't need to prove their efficacy in the same way that public health or medical interventions do. And there's certainly some truth to that, because the evidence that we do have for more punitive measures has really been negative. And so this was a study that was published in JAMA last year, showing that the displacement of people who are experiencing homelessness who use drugs increases the risk of overdose and negative health effects. And again, that displacement is a policy decision. It's ultimately impacted, it's implemented by staff members, agencies, et cetera, but it's ultimately a policy decision of how are we going to address individuals who are experiencing homelessness, in some cases, individuals who are also using drugs. And so this is sort of one example, one study that was sort of done showing the impact of that. Another example is drug seizures, which have been associated with increased overdoses and overdose deaths. And this was another paper that came out last year, looking at Indianapolis, that was published in the American Journal of Public Health, showing that very quickly after a significant drug seizure or a drug bust, the immediate area in the surrounding 100, 250, and 500 meter areas, radii, there was an increased number of fatal overdoses. So it really is, again, this comes back to the point around how policy really is important for us to be thinking about in all of those sort of four pillars that we're using and other places have used as their framework for addressing substance use. But I do want to say there are also a lot of opportunities for policy to do good in this space and to make some important changes that are, in fact, overdue, I think many of us would probably feel, in order to stem this tide that we're seeing of overdose deaths, but also sort of all the morbidity associated with substance use as well. And so the first slide that I'm going to put up here was, this was for the first time, that I'll say that my colleagues and I are aware of in this department, but then also those of us who participated in this workshop of the National Academy of Sciences, Engineering, and Medicine, has a federal office basically commissioned a intensive look, asked the National Academies, asked the National Academy of Medicine to do a deep dive into harm reduction in general and harm reduction services. And so this was a workshop that was held 2 weeks ago. The recording is now available up on the National Academy's website, but it was really bringing together experts from across the country to explore data collection, evidence gaps, and research needs. And this workshop was sponsored and commissioned by ONDCP, so our Office of National Drug Control Policy. And I think it revealed to us that for as much as the pendulum is swinging, there is still a push by parts of government to lean into harm reduction, to think through what are some of the policies that could be pursued to promote the use of and uptake of harm reduction. So this was a welcome event. I would say that I learned a lot from it and found that it was a very inspiring, albeit at times challenging, just to hear the challenges that some colleagues, are facing across the country. It was still also very inspiring to see people who have been really steeped in this for decades, really being able to talk about this and moving the field forward. One of the more recent changes that I want to sort of share with this group, many of you may already be familiar with this, but this was recently issued earlier on this month, was that HHS issued a new final rule on methadone treatment, which is really intended to expand access and improve the quality of that care in OTPs. So this was published at the beginning of February, as I mentioned, and what was notable about this is that this is the first significant revision of federal methadone regulations in about 20 years. And among the changes, this new final rule allows for earlier receipt of take-home doses, which really took off during the pandemic, but now this really makes those permanent and really allows for earlier receipt of take-home doses. It allows for a higher starting dose of methadone, recognizing that people who have been now using fentanyl for a long period of time do have higher tolerances, so this allows for a higher starting dose. It allows non-OTP practitioners to help facilitate intake, so to do some of that initial assessment and exam. That could be done by colleagues for example, here, it could be done by colleagues in street medicine, so that when they get to one of our OTPs, that step is already taken care of, hopefully facilitating intake. Individuals with moderate to severe OUD can receive methadone immediately. They are not required to have OUD for more than 1 year, which was the previous requirement. And then receipt of methadone is not conditioned on receiving counseling. For a lot of individuals, counseling is important and can very much be beneficial, but that shouldn't be a requirement to getting the medication itself. The effective date of this is April 2nd. And now what we're sort of working with in the city here is trying to work with our partners at the state level to ensure that state regulations and federal regulations are aligned. There are areas of inconsistency that need to be reconciled because California regulations are now stricter than some federal regulations. And if we do not address that, our OTPs in the city and across the state will not actually be able to implement federal regulations. This is a big step forward, I think, for methadone and making sure that it is more available to individuals who need it. There are still efforts, though, to take it further. And there is a bill now that has not been passed, has not been signed into law, but is sitting in the federal government called the Modernizing Opioid Treatment Access Act that would further sort of liberate methadone. What this bill would do, it would allow for addiction-trained physicians to prescribe methadone for OUD treatment that could then be picked up at retail pharmacies. So it's now removing care outside of OTPs. It would require DEA to create a new registration process for such prescribers of methadone. So in some ways, what it's somewhat doing, for those who are familiar with and think a lot about what previously existed for buprenorphine, this X waiver, this is sort of mimicking it. It would allow addiction-trained physicians specifically to prescribe it in outpatient settings and someone to go pick it up at their pharmacy. This bill then fixes that contradictory policy that we have, that methadone currently can be prescribed for pain, but cannot be prescribed outside of OTPs for OUD. And so this fixes that contradictory policy. It establishes additional federal safeguards for such prescribers and allows counselors and other ancillary services to be provided via telehealth. I would say this is slowly making its way through Congress, but it's not without a lot of pushback. As you can see from this headline from Stat News, methadone clinics spar with addiction doctors on a bill that would widen access. Some of the greatest opposition to this has come from the American Association of Opioid Treatment Providers, who have sort of promoted this campaign called Program Not a Pill, really trying to make the case that it's not just about the medication, it's about all the other sort of services that come with an OTP. And so that is sort of where this debate is now landing, is really putting in many cases, the association of OTPs, the trade association of OTPs, in opposition with the American Society of Addiction Medicine. So stay tuned. More is to come about this specific act, the Modernizing Opioid Treatment Access Act, or MOTA. On the other end of the spectrum is thinking about safe consumption as an evidence-based intervention that remains unsupported at the federal level. I won't read through this entire opinion of the court, but this was an opinion that was put forth by the Third Circuit Court of Appeals in response to a case out in Pennsylvania, specifically Philadelphia, in which DOJ had sued Safehouse, and Safehouse had This had been litigated by Safehouse, which was the nonprofit organization that was hoping to open what would at that time have been the first safe consumption program or overdose prevention program in the country. But basically this court found that that was going to violate part of the federal law that is sort of known as the crack house statute, basically pointing out that even if Safehouse's intentions were admirable, it did not allow them to operate an overdose prevention program. So there is not support for this. It was appealed up to the U.S. Supreme Court, which declined to hear the case for the Eastern District, or for the Third Circuit of the country. And so it remains unsupported at the federal level. But what that has left is sort of this patchwork. Without federal guidance, the fight over safe consumption is sort of being waged at the state and local levels. And these are just a handful of headlines that I pulled for this sort of presentation to sort of just show that now we're left with this sort of patchwork of policy that are going in both directions, right? We have the headline at the top left here showing that Rhode Island Governor McKee signs legislation allowing safe injection sites into law. Rhode Island is moving quickly forward and will likely open the first state-supported safe consumption site in the country later on this year. The Vermont House just approved a bill that would allow this, although it's likely to run into opposition at the state Senate level. Minnesota approved this as well, although it is also running into some opposition. Pennsylvania, on the other hand, the Senate voted to ban safe injection sites. New York Governor Hochul rejects using opioid settlement dollars to expand on-points efforts effectively, safe injection sites or safe consumption sites that are operational in New York City. And then in Philadelphia, coming back to this work here and Safehouse's work, is that City Council actually, this headline is a little bit, there's a lot of sort of like almost like double negatives here. But City Council overturns mayor's veto on safe injection site ban. City Council in Philadelphia basically legislated that safe consumption sites could not exist in Philadelphia. Mayor Kenny, in one of his last acts as mayor, vetoed that, and then City Council overrode his veto, making it basically illegal, not permissible to operate a safe consumption site in Philadelphia. I would say, though, that this is also pointing out the opportunity that states have to be innovative and to think about how is it that we could use state-level legislation or state powers, perhaps, to advance evidence-based interventions, improve access to treatment, support harm reduction. And so one of these bills is one that's currently that has been introduced, which would allow for 72-hour methadone dispensing from non-OTPs. This was introduced by San Francisco Representative or Assembly Member Matt Haney. And again, it would allow non-OTP clinics such as the Bridge Clinic, which is the screenshot on the right, to dispense 72 hours of methadone while someone is being referred to an OTP. If passed, this would go into effect beginning of next year unless an urgency clause is added to the bill that would allow for expedited implementation. I'm going to go through the last couple a little bit quickly here because I'm realizing I'm running out of time, and I'm sorry about that. Second one here was just introduced earlier this week, so this is sort of hot off the press, but is a state bill that would require wastewater testing for high-risk substances, as it were. And so this builds upon the use of wastewater to track COVID-19, but it would require local wastewater agencies, such as our Public Utilities Commission, to collect wastewater samples and test them for high-risk substances, including fentanyl, cocaine, methamphetamine, and xylazine, as well as their metabolites. This bill would require our state Department of Public Health to analyze trends and publish them, and would basically is sort of trying to build upon work that we are currently participating in San Francisco, in which we are contributing to a 70-site NIDA-funded study in which our wastewater is being tested for these substances. And effectively, what it is, the process is laid out here on the right. This is from the European Monitoring Center for Drugs and Drug Addiction, who have been doing wastewater monitoring for many more years than we have been. We just started in early December. But samples are collected from multiple sites. They are then, the flow rate is calculated, the amount of target residues is calculated. You adjust for some, human metabolism, the rate at which waste enters our water supply. From that, you actually can build a population estimate, which is one of the reasons why we've been interested in this, is that, as I mentioned before, so much of our data captures individuals when they receive a service, or unfortunately, if they die, but we don't have a great sense of the population size of individuals who may be using substances. So that's what this is sort of helping us with. That's sort of where we are ending it right now, is that our data will be reported next month publicly in milligrams per day per 1,000 people. It's not going to be calculated in dose, which is sort of what NIDA has specifically, is keeping us all to reporting it in the same way, is milligrams per day per 1,000 people. My last couple slides here are now transitioning just to sort of like, oops, I have one slide here about Oregon Measure 110. I'm happy to come back to this and we can talk more about this, but this is what was done up in Oregon around decriminalizing small amounts of drug possession. So instead of getting arrested, people basically get a citation. This was the first in the country. It's generated quite a bit of controversy, and in fact, efforts are now underway to try to roll back the law. And so it's so early, I think, to still sort of assess all the effects of this, but I sort of just want to share this as another ways in which states have been able to craft policy and implement it in the absence of some federal guidance. But I do want to end with just a couple slides around local legislation and local policy, because I think there's still opportunities for us to think about policy at this level that may have just as much of an impact, albeit on a perhaps smaller scale, a smaller population. But the first example that I'm just sort of showing here is about local legislation that supported syringe service programs back in Philadelphia. And so what you see on the left here is the number of new cases of HIV among people who were injecting drugs, dating back to the early 1980s all the way through 2016 or so. We had this very steep rise in the 1980s and early 1990s during the AIDS epidemic. In 1992, it peaked with 819 new HIV diagnoses among people who are injecting drugs. That was the year that then Governor Ed Rendell, then mayor, and then former governor, Ed Rendell issued an executive order allowing syringe services to come above ground. So that was in 1992, and you can sort of see this profound decline that happened sort of since then. This was subsequently studied using an interrupted time series analysis showing that an estimated 10,000 cases of HIV were averted due to the efforts of Prevention Point, Philadelphia, which is the syringe service program in Kensington, saving over $240 million per year for each of the first 10 years of its operation, making this a profoundly effective intervention that has both saved lives as well as billions of dollars. Locally here, a bill was recently passed that requires San Francisco retail pharmacies to stock naloxone and post signs about its availability. That was informed by this study that you see on the left here from the Lancet, highlighting that naloxone distribution from pharmacies is an important source of naloxone distribution. It is arguably not as important as community-based distribution programs, people who are programs that are distributing naloxone directly to people who are using drugs who may be at high risk for an overdose. But pharmacy distribution shouldn't be ignored either. And so this bill, again, went into effect earlier on this year and requires our retail pharmacies to stock naloxone and post sign about its availability. Lastly, sort of national and local litigation has resulted in billions of dollars being directed to mitigating opioid overdoses. So the screenshot on the left here is about policy litigation as sort of the policy lever to change the course of our public health and overdose efforts. So the screenshot is from when the city attorney announced the $230 million settlement with Walgreens. In San Francisco, those dollars are being treated as general fund dollars, although they must be used for abatement purposes. It is more than $250 million, but it is being paid over 18 years. So there is a long window in which these are all being paid out, meaning that each year it's actually not quite the large bolus, not the large infusion that we had once hoped. Proposed uses from DPH that we have put forth that are currently being reviewed by the mayor's office are medications for opioid use disorder, contingency management, overdose prevention and supportive housing, and then really reducing our racial disparities. Here are just a couple of points that I want to sort of share that I think researchers could get involved with, can think about, is, in terms of getting involved in policy, and maybe that's what I should have titled this, is what researchers can do. You're obviously all doing a lot, but what you can do in terms of the policy space is, articulate the problem you're trying to solve and how your research can help solve it. Understand where your policy levers may be. Maybe that's executive order, like the syringe service example that I used, legislation such as our naloxone ordinance, regulations such as the HHS methadone rule, or litigation such as the opioid settlements. I would say don't underestimate the importance of institutional or local policies to make a difference. As Alyssa mentioned sort of in the introduction, I did a 2-year fellowship in health policy research, and really am grateful for my colleagues who are doing complex analyses using large national databases. That is very important work. I will also say that what our policymakers over in City Hall are thinking about are local data. It's doing good descriptive analyses. It's doing some simple 2x2 tables. It's doing some surveys and presenting local data. And that can really make a difference. What that naloxone bill, for example, it was just us estimating, calling around, doing a secret shopper survey, how many pharmacies were stocking naloxone in the city? How many were not? What kind of a gap is this? So I would sort of say, please don't underestimate the value of institutional policies or local policies, because those can very much make a difference. And then really share your research with policymakers and be a resource. The picture on the right here is a law review article, but I just sort of bring it up because it's been put forth as a way of moving towards a safe supply. It's actually thinking about how might we offer hydromorphone in this case to individuals who have both OUD and significant pain. And this was something that was brought up as a way of addressing the policy challenges around a safe supply, as it were. And then lastly, I do promise this is my last slide, my final thoughts. Thank you for the chance to be here today. I appreciate this. Today's overdose crisis, as you all know, is tremendously complex, rooted in racism, stigma, and historical inequities. Expansion of evidence-based prevention, treatment, and harm reduction strategies is necessary, but not sufficient. I believe that policy shapes the conditions, for these programs to be implemented and the conditions for people who use drugs to participate meaningfully in those programs. Opportunities to affect policy change exist at every level of government, as well as within organizations, UCSF, ZSFG, nonprofit organizations here. All of those are needed and will make a difference. And so I won't read this quote on the right here in its entirety, but on the right there is Sam Rivera, who is the executive director of On Point in New York City, and he visited us in San Francisco last year and then again earlier this year, speaking to our board of supervisors about the importance of safe consumption and harm reduction, and just the humanism with which he speaks about this and shares his work, which is how I would like to end this talk. And so saying harm reduction is the epitome of meeting people and loving on them until they're ready to love on themselves, truly being there at a time when they need you more than ever at the most crucial times in their lives. I'm blessed to have the most amazing staff on the planet who show up every day just to love on people in any way possible and not judge them and not to experience them in the way that other people's do. So with that, I'll end and say thank you very much. And I'm happy to answer questions, but also happy to ask some myself for people's thoughts and feedback.
Jeff, thank you so much for a thoughtful and provocative set of discussion points. I will open the floor for questions.
Hi, may I ask a question? Hi, my name is Veronica Masharkova. I'm a pediatrician and adolescent medicine specialist who's also board certified in addiction medicine. I'm wondering if you could speak to DPH efforts that are specific to youth who are struggling with substance use and addiction. Thanks.
Absolutely. Thank you, Veronica. That is an area that we are currently sort of working to develop. I'll just sort of say this very upfront and would love your thoughts and expertise in thinking about how we might do that. And appreciate how busy you are, but if it's time to follow up, I would love to do so. When we've looked at our data, and I'll say that unfortunately, our best data are our fatal overdose data, which I recognize is not by any means the world of data that is important to be looking at. But I'll say that it's one of the things that we have most ready access to. Unfortunately, over the last several years, we have not had. I think there's been one over. Let me actually not quote a number because I might get that wrong. But over the last several years, there have not been any at all among young persons. That said, we recognize that it is very much a possibility, and we don't want to wait until we start to have increasing numbers of them to then say, oh, we should do something. So we've been starting to work with our colleagues down the hall here in our children, youth, and family services who have been holding more of the prevention work with youth and families in our department to see how can we sort of support some of their work, how can we bring some of this education into schools and after school programs, how can we think about working with pediatricians and other pediatric providers, and how do we think about utilizing some of the bills that are now making their way through the state legislature that are going to require schools, school nurses to have a role in thinking about having naloxone on hand. I will say that it's very early. We have just started to draft some materials that we want to send out to schools to say, we're here as a resource. How can we support your work? But would very much welcome a chance to talk with you and others about that.
Howard.
Yeah, so you have those 2,500 patients in methadone, and you have about the same number in buprenorphine. Do you have any data on overdoses in that group, those two groups?
Good question. I'm trying to think of how we do have those data. The short answer is yes, in that we can match our overdose decedents with our list of individuals who are receiving methadone in the city here, and we can match our overdose decedents with individuals who are receiving buprenorphine if they have received buprenorphine from part of the San Francisco Health Network clinics.
Yeah.
So, and your point is going because those are analyses that we would need that are important to do to understand the frequency with which people may still be having overdoses while in treatment, or have they recently stopped receiving treatment for some reason. I would say when I've talked with our chief forensic toxicologist in the medical examiner's office, buprenorphine shows up very, very, very infrequently, fortunately, which I don't think we're totally surprised at, but fortunately it's not showing up in high volumes here. Methadone, I don't remember exactly what the numbers are. It certainly does come up once in a while, but also not in high volume. But just understanding that intersection is important.
Well, at least there's a denominator. So
True.
and then I don't know how many people use drugs in San Francisco. It may be difficult data to get. There is one medication that you didn't mention, which is depot naltrexone. I mean, it's used to treat alcoholism. There certainly is comorbidity of alcoholism, cigarette smoking, and multiple, drug use. There is some evidence, it's not really great clinical trials, but certainly reduces the incidence of DUIs compared to doing a few days in the drunk tank.
You're absolutely right, Howard, and thank you for pointing this out. That I did, and admit that I generally do not spend as much time sort of bringing up and focusing on extended release naltrexone or Vivitrol, and it's really based on the data that we just have and that we really rely a lot on is the mortality benefit is just obviously not there in terms of overdoses, in that both buprenorphine and methadone reduce the risk of dying by up to 50% for individuals who are on them. And Vivitrol, for whether that's because it doesn't have the same ultimate efficacy, because the N is just hasn't been shown to do it because the N has been too small. I don't fully know, but it just does not have the same mortality benefit. And so we have been sort of really doubling down on buprenorphine and methadone when I do bring up MOUD. But you are right. I mean, that it is FDA approved for the use in individuals with OUD, but we have been investing.
The reason I bring it up is certainly not a surprise that buprenorphine would reduce the incidence of overdose because it's got a ceiling effect for respiratory depression. That's generally the cause of death. But naltrexone should block, the action of any opioid. I just don't know whether when it's given as Vivitrol, it's in high enough concentration. Should last for about a month. People may not want to take it more,
Well, it is. So I think it's an important point, though, because I think there are, and we've heard it from some of our providers within BHS here and within, our pharmacy downstairs, for individuals who may want to receive a treatment, receive a medication, but do not want to receive an agonist, I do want to make sure they have that option. And certainly for some individuals, if they don't want to receive an agonist, partial agonist or full, and they're open to, extended release naltrexone, I don't want to. I'm sorry if I probably have sounded a bit dismissive about it. That's not my intent. It probably does a little bit, but your point is a good one.
Okay.
That from our perspective, we still want to make sure it's available, but that's sort of why I don't include it very much in my talk.
Okay, thank you.
Jeff, we have about a couple minutes left. You said you had a question for us. Do you want to share and maybe someone can answer here?
Yeah, I mean, one of the questions, and I ask this of everyone when I can, is that question that I sort of posed at the very beginning when we were looking at that map. And again, recognizing that roughly 70% of our overdose decedents are dying indoors somewhere. So in some cases, those are SROs or permanent supportive housing, and we have ways of potentially trying to reach those individuals. But individuals who may otherwise have their own homes and they're just using in the privacy of their own room, I don't have a way that I've sort of seen about really sort of reaching that population. And so I always ask this question, if you have ideas or thoughts about reaching that population, I'm always open to hearing about them. It doesn't have to be now. If you have a thought later, please send me a message.
Jeff, can I would love to answer your question with a question, actually. This is Leslie. We've met before, DGIM, assistant professor, also a clinician at OBIC. I'm really curious because, one intervention that has gained national attention in recent years is the Never Use Alone line. So sort of allowing people to call a hotline if they're using and having someone stand by. And I feel like that's not really something, I think it's more popular in places like Massachusetts and the East Coast, but it's not really something that I've heard patients talk about. And when I share it with them, they're like, wow, I've never heard of that. That's great. I will use it. But I don't know why it hasn't really been implemented widely in San Francisco, even though, of the patients that I talked to, my anecdotal clinical experience is that people like the idea, especially, with the recent podcast that I forget, This American Life did.
Nice. Yeah. Yeah. Thanks, Leslie. That's a great point. I would say that Yeah, I think that's a great point. I think that it is something that we have distributed in some of our materials, but I'll very fully admit that it's not to the scale in a way that it probably ought to be, or certainly should, ought to be. We have thought about over the coming year doing some more really around like actual campaigns around raising awareness. I'd love to, yeah, I mean, I'd love to follow up with you about this and think about how can we do this more. I think we probably have it some way done with some of the facilities that our BHS pharmacist goes to, which may not be, which are not maybe the highest priority for this sort of knowledge. And so how we get this out further would be great to think about.
I agree. And then there's also, our community partners who are doing this frontline work day to day. So I know Wes Saber is on the call, but really looking forward to talking more.
Thanks, Leslie. And thanks for your comments in the chat, Wes.
We do have one question here that I received from Anna in the chat that I'd like to read before we close for the day. So thank you for everyone who stayed on. The question is, what is your thought on ketamine for its opiate sparing effect to assist in getting off opiates? Yeah.
So I will say that I do not have the most informed thought around this. I will say, though, that from what my understanding has been, and again, I think it's probably, I would say, very rudimentary compared to this group's probably knowledge about it, is that I think it's just so important that we're thinking about all of these other interventions, including ketamine. I'm sorry, that sounds like probably a very political-ish answer, but I say this because one thing that I've sort of heard as I've talked about sort of policy especially, or just what are we doing around overdoses is like, well, how are you expanding like the things that work? And I think expanding what we know works is really important. I think it's like we have challenges with our OTP system. We have challenges with accessing buprenorphine here in the city. And we can improve upon those. We can do things new, better, and different with regards to the tools that we have. But I would also say, though, that I'm not sure that simply scaling up is enough. And that if we don't start thinking about these innovative ways, how do we think about incorporating more contingency management across the entire system? Thinking about other sort of potentially, pharmaceuticals, other medications that could have an impact on specifically perhaps OUD and overdoses, pain, mental health more broadly. I'm not trying to just sort of say we should be pushing medications right and left, but I think that it's really important that we not ignore or that we don't just that we take anything off the table, to be honest, as it were. That's sort of my
well, thank you. Can you hear me by chance?
Yes.
So it's Thaisa Cherry, and so I do a lot of ketamine, IV ketamine for pain, for depression. And I do have patients that I'm getting off high dose opiates that are sent to me by other people. And so I can give IV ketamine infusions, and then we reduce the opiates at the same time. It is somewhat labor intensive. And so this idea that you can do this on many patients, but there is some data and some articles on microdosing of ketamine for opiate addiction and to reduce opiate addiction. The complexity, which I think you're sort of speaking to a little bit, is that like, how do you give somebody ketamine and then control and monitor the ketamine at the same time you're reducing their opiate use? And then you've got ketamine that you've now added to the whole equation. Nonetheless, with regulation and by IV at any rate, you can kind of dramatically reduce opiates for patients that are on high dose opiates prescribed, but nonetheless sort of had been inappropriate opiate dosing. But then it's sort of how to implement that in any kind of a policy. But that's why I mention it right now, because it is an interest of mine.
Thank you for that. I appreciate that. And
yeah. Great. Thank you for these questions. And thank you, Jeff, again, for a wonderful presentation today. I think we had very good attendance, and certainly I learned a lot, and was happy to find out what's going on in San Francisco and where the challenges lay.
Well, thanks so much, everyone, and thanks for
Thank
the
you.